Cervical length assessment on ultrasound scan is the topic of our discussion today. Assessment of cervical length via TVS in the mid-gestation foreshortening or funneling is the most reliable method to predict preterm birth. Measuring the cervical length is an essential obstetric ultrasound task for primary purpose of predicting the preterm birth. Preterm birth is defined as the delivery regardless of the mode before 37 weeks of gestation. Preterm birth is an adverse pregnancy outcome with significant implication on the neonate and family. Predicting preterm birth in patients with a short cervix may lead to interventions that prolong the pregnancy to optimize outcome, even allowing pregnancy to reach full term. When to measure cervical length? Assessment is generally completed for screening purposes at mid-gestation, usually during the anatomy or morphology ultrasound between 18 and 24 weeks. Although the Society of Maternal Fetal Medicine recommend routine TVS for both high-risk and low-risk patients, many centers continue to evaluate through TAS as a first line. If an abnormality is identified on transabdominal ultrasound, one may yield a more clear assessment of the cervix via TVS. Very likely, the decision to perform only TAS is in part due to combination of the culture and convenience. Funneling of the cervix. Cervical funneling was defined as protrusion of the amniotic membranes of equal to or more than 5 mm into internal os as measured along the lateral border of the funnel. This finding is usually accompanied by short cervical length defined as less than 25 mm. How to accurately measure cervical length? First of all, the cervix should occupy a large portion of the image. The anterior and posterior cervical thickness should be similar. Calipers placement should be appropriate. A minimum of 3 measurements are taken over 3 minutes. A straight line or using segmental approach can be used depending upon the curved nature of the cervix. The presence or absence of the funneling should be noted. The unique requirements for TAS approach include, first of all, ensure that patient is in supine position with as close to 0 degree as possible. Secondly, a full bladder is not usually required, but some urine in bladder may optimize the chance of acquiring an adequate image. The requirements for TVS include dorsolathormy position, empty or near empty bladder. The right balance of presence and image quality needs to be achieved, and suprapubic or fundal pressure may be applied. Some centers argue that there may be value in performing assessment early in the gestation during 11 to 13 plus 6 weeks for the same purpose of evaluating the risk of preterm birth. In combination with a clinical history, cervical length at 11 to 13 plus 6 weeks interval may detect roughly half of the pregnancies delivered before 34 weeks of gestational age, with only 10% false positive rate. Assessment of the cervix via TVS in the mid-gestation foreshortening or funneling is the most reliable method to predict preterm birth and attempt to positively influence the remainder of pregnancy, optimizing obstetric and neonatal outcomes. Cervix can be visualized on TAS as well, but poorly. When we talk about full bladder and cervical length, we find out that full bladder can artificially increase the cervical length, but at the same time it can obscure the presence of cervical funneling. So it has got both pros and cons. One thing to remember is that there is segmental thickening of the lower uterus, so be careful not to overestimate the cervical length. Here you can visualize the cervical mucosa. Here you can see the segmental contraction of the lower uterus. Here is a case: patient rushed in at night for an obstetric emergency cerclage. So the first scan show outpatient scan and funneling has been detected, and the second one is shown upon admission. The cervix is soft, so avoid undue pressure. Here you can see the proper technique to visualize and measure the cervix with vaginal sonography. First, exert some pressure to identify cervix and cervical canal. Secondly, release completely the pressure to measure the cervical length. Here you can see the contingent use of the fetal fibronectin and cervical length in preterm birth. So when we measure the cervical length at less than 15 mm, size shows the high risk, more than 30 mm shows low risk. But if fetal fibronectin at 15 to 30 mm is positive, that is high risk, and if it is negative, it is low risk. The protocol for cervical length assessment include patient in gynecological position, empty bladder, vaginal probe of equal to or more than 5 MHz in lubricated disposable sheath. Gently place the probe in the anterior vaginal fornix and ensure a sagittal view of the cervix is obtained. Obtain a large image of more than 75% of the screen. Identify the internal os, external os, cervical and canal endocervical mucosa. Be aware segmental contraction of the lower uterus. Avoid excessive pressure with the probe because it may cause inaccurate estimation of the cervical length. Take time, at least 3 measurements, and use the shortest one. Thank you so much. That was something about the ultrasound measurement of cervical length and its significance. Subscribe on Obs and Gynae. Follow the Facebook page of On Obs and Gynae. Allah Hafiz.